Hi, I'm Lowri. I'm the chronology team manager at MedBrief. Before I joined MedBrief, I was a solicitor practicing in personal injury and clinical negligence.
Hi, my name's Paige and I'm the clinical operations manager at MedBrief. Prior to working at MedBrief, I was a nurse working in end-of-life care. In this episode, we are talking about end-of-life care from a nursing perspective and how this impacts on legal processes.
End-of-life care is quite a difficult topic for most people, and I'd imagine it's quite a difficult clinical area to work within. Why did you choose to work within that clinical area?
Yeah, so when my brother was 16, he was diagnosed with a brain tumour, and he was obviously very young to get the diagnosis that he did. So when I was actually working at a law firm prior to him becoming unwell, and my brother's experience of being sick, having a brain tumour, having treatment and things kind of made me want to go into the area, because even though being a nurse is normally about making people better, there is such a thing called, a good death, and it's good to because of my brother's illness, it kind of forced me and my family to focus on good end-of-life care, because he reached the end of his treatment line and the only option then was end-of-life care. And as his family, we advocated a lot for a good death, so that he could be comfortable and he could have it how he would have wanted it. So that's what made me go into end-of-life.
So given sort of the fact that you've had quite a personal relationship with end-of-life care, I'd imagine it's quite a difficult role to you have to have empathy, but you've got to remember that that isn't important in the room at the time. The patient is important. How do you sort of tackle that?
Yeah, so it's a lot, mostly about effective communication. When I was training to be a nurse, it's a lot about preventing death, and you do your BLS training, and you do everything that you could do to recognise the signs of a deteriorating patient. And then all of a sudden there's a bit of nursing that it matters, that it's about actually just about death and about making sure that is okay and pain free. And I would say that communication is the biggest thing, because if you don't give people their options or communicate with them and communicate their options to them, then they don't know how they can die. They don't know that they can die at home and that they would be correctly supported in doing so.
The cases that I predominantly worked in, because I did a lot of oncology work, had a lot of my clients were on end-of-life care. But that usually came in from a perspective that there was a delay in 2-week wait referrals, presenting to GPs with symptoms, that not being picked up at that point. And then obviously the delay in diagnosis impacting choice of treatment, the fact that it metastasized, that sort of thing. So I had a lot of people who were on end-of-life care. I did things like, I took deathbed statements and things like that, which is why I sort of asked about how you dealt with you have to have empathy for the situation, because I don't think it's a job that you could do without having that empathetic part of you. But if you don't put that wall up a little bit, I think you would just spend every day in floods of tears, because that's the sort of thing that you're dealing with. So, for me, it was sort of finding a balance between being supportive and empathetic, whilst also recognizing you're not the most important person in the room. You need to be there to do the things for them, but respect that it's their decision, their choices. But I guess I see it from a different perspective, because I'm there from a legal capacity, not a clinical supportive one then.
Yeah, I understand that it is difficult, and I think that the most thing that you can take from it, and what I used to do to separate it, is yes, it's sad, and especially you'd have there's patients that you would be expecting to die, and then there's patients that are not, and my brother was one of those. So every time like the district nurses that came to view that came to like help my brother, they all received counselling from their trust afterwards because of how upsetting it was for them, because it's not somebody that they would expect to see within their care. But what I used to take from it is all of that support that my brother and my family felt from those nurses, like whilst they were obviously trying to process it in their own minds, and it, you know, it would obviously have been difficult for any nurse to do, but what I would take from it, from the professionally, is providing a good death and providing all of the organisation that goes into that. So when I worked at a hospice, I would organise everything for patients to be at home regardless of how unwell they were, so that they would have everything set up. They would have a hospital bed, they would have all of like pressure relieving equipment, and it would give me a lot of satisfaction from giving a patient a good death, as opposed to making a patient better, that they can go ahead and live their lives. So I suppose it's like looking at it from a supportive way, but supporting them in death as well as how you would to try to get somebody better. It's obviously a lot better to see when you have nursed somebody that is recovering from surgery, that you're going to expect to then get up and be walking when they wasn't previously and feeling better. But there is still satisfaction in being a comfort if they need support, but then also to be an advocate to make sure that they get the death that they want.
And I'd imagine as well, sort of the family play a really big role in end-of-life care. Like, for example, from a legal perspective, I remember that it was actually the first day of my training contract that the solicitor that I was training with at the time said that this isn't a job, this is a vocation. And the longer that I did it, you realise that, yeah, you can't do this and view it as a job, because specifically with clients that pass away, the claim doesn't stop. So not only are you supporting, when you're running the claim, not only are you supporting that person, and you have to maybe restructure or shuffle the way you would usually run a claim, because unfortunately there is a different timeline you're now following because that person is having end-of-life care. But when they do sadly pass away, at that point the family pick up the claim. And not only is there a lot of emotions involved in that, there's a lot of legal stuff that needs to be done. So, for example, you need to make sure that you are discussing and taking instructions from the right person. So that's getting wills in to see who they nominated to deal with their trust, their estate, sorry. And also, if they haven't got a will, you have to follow the rules of intestacy. So maybe the person that has been supporting our client through this process isn't the person who would be taking over. So for us, it can become a little bit difficult, because when that person passes away, it doesn't end for us. And it almost becomes, at least for me it did, that it's a different type of claim now, because the person is coming from the perspective that they have lost their loved one, which makes it a very difficult process. How involved is a patient's family?
Really involved. So obviously, you know, there's a lot different stages of death. If a patient is imminently dying, then a lot of the communication will be had with their family. There is a real big importance of distinguishing reversible versus irreversible deterioration. So anything when a patient is end of life, it would, if any potential breach happened whilst they were receiving end of life care, so for example, failure to recognise pressure sores or early signs of pressure sores, or potentially they didn't have the correct mattress that they should have, but then and also their risk of falls and their mobility deteriorating. It's obviously really important that we get that information from the family, especially when the care is intermittent. So it doesn't have to be daily, not as it would be in an acute hospital. But in the community, the care is, if somebody is end of life but not actively dying, they might only be seen once or twice a week. And it is vital that you have the conversations with the family to know how they are deteriorating so that the correct measures can be put in place. Being informed by the family is really important for end-of-life care, especially when the patient is non-verbal or too poorly to talk, and they're deteriorating in like physical capability. That it's really important that the family will give information on their skin integrity. So for pressure sores, it's really important that is communicated with staff, especially from in a community setting. We would would have in-depth conversations about the patient's wishes and how what anything that could be done from our perspective to make that death better, and how it would inform the care. So we have there's obviously an issue with pressure sores in the community, and mobility issues such as falls. Do you see that from in a legal capacity?
Perspective, actually, I have actually specifically run a case involving pressure sores with a patient who was in end-of-life care. So even though there isn't actually a breach that's contributed to the claimant's death, things like pressure sores, fractures from falls and things, actually both in hospice and community care. From that perspective, even though the breach, it hasn't impacted them from a perspective as that it has caused their death, it impacts their quality of life. And as you said at the beginning, the ability for them to have a good death. So there are cases that are run like that. So obviously from an overall perspective for a family, it's more so the fact that it has impacted their quality of life. The family and the claimant already had to accept a situation in which that person's going to pass away. And it is sad that they put a plan in place that they have agreed and everybody is happy with, because there are a lot of procedures you have to go through, legal documents, medical documents, and you've sort of done that and accepted that that's something that you have to do for your family member. And then when that isn't followed, or there is a breach in their care, it's a really difficult one to accept, because it's already on top of something that you've had to accept a really difficult thing. And it is a really difficult claim to run, because at that point, it's usually that you actually haven't met the person who's passed away. So it is the family that you're dealing with. And I think it's why it's very important that all of the documents that can be put in place are in place for that particular person, because this sort of then leads into sort of sealing of care. Now, that's a term that I'm aware of, but obviously limited understanding of that in practice.
Yeah, so for a sealing of care, a patient would have a wish to, if they've got a reversible injury, so for example, if they're end of life, but they have had a fall and they've fractured their ankle, even if their sealing of care is that they don't want to be hospitalised and they wish to stay at home to die, or they wish to stay in a hospice to die, anything that is able to be fixed, such as a fractured ankle, they would go to hospital for, so that can be treated because it's reversible. And then their ceiling of care would be that they just don't want any life-saving measures for their actual condition. We see it a lot with DNAR documentation, so do not attempt resuscitation. It's not a legally binding document, but it does help to inform clinical care, really, so that if they make a decision that they don't want to be resuscitated, and that's a lot to do with communication between between medical clinical professionals and the patient and their family. The patient obviously has a right to be involved in that decision making, and it will inform the care that they receive when they're in hospital settings. There are more localised terms, so like a TEAL form, which is where I used to work. That was that was any treatment escalation, whether or not they wanted to be fed if they stopped being able to swallow. That is all from communication with the medical team and with the patient and their family. For ceiling of care, you would need that to be documented clearly, so that anybody involved in your care going forward would know that you would want an ambulance to be called if you had a fall, but you wouldn't want to have an ambulance called if your condition was deteriorating.
Right, because that sort of comes into potential claims as well. Like you spoke about the issues of mobility and falls and things like that. Now, if you've got somebody whose choice is to be cared for at home, a fracture then can take that choice away. So there have been scenarios in which somebody doesn't want to be in hospital and doesn't want hospitalization is the main thing that they're concerned about. That takes that option away. So that's another thing that can be dealt with from a claim perspective. So a prolonged inpatient period. And obviously, you've got a person who is already unwell now in an environment that maybe isn't the best scenario for them because they're in hospital with other people who are unwell. I have seen cases like that, which just by them being in hospital can impact their health, because it isn't the best place for them and they wouldn't be there had it not been for that fracture. Have you seen scenarios like that in practice?
Yeah, definitely, especially with cancer cases. So when you're at end of life of a cancer patient, depending on if you're still having treatment, you can obviously be immunocompromised. And then if you make a decision not to be hospitalised, but then you go into hospital because you have a reversible cause, such as a fracture, for example, you going into an environment that is full of other people that are unwell and you are immunocompromised, which is not necessarily safe for somebody that has just recently had cancer care. Even as a young person, I have been forced to question my own mortality, especially being a sibling survivor of my brother dying so early, and that has made me more comfortable with having conversations around death. I am a big advocate for preparing for your own death, regardless of how young you are, not in a depressing way, but in more of a way that you should be clear on what you would want if the worst was to happen, and to have that either told to a loved one or just spoken about, so that you know what you would want in those type of scenarios. It's important because even though it feels like, hopefully we live long lives and we don't have to have too much time to consider it, it really matters when it matters. And to communicate about it effectively, especially in a professional capacity, it allows for decisions to be made that you don't even know are decisions that you can make. So if lots of people avoid the topic of death because it's uncomfortable and it doesn't feel necessary, but it isn't necessary until it is. And especially when somebody has a life-limiting diagnosis and they need to talk about death, the stigma around death makes that so difficult because you almost don't want to, because as I said previously, if you go into a hospital, lots of people expect to be cured or made to feel better or a broken bone fixed. However, there are certain scenarios where that just isn't an option. And I think that with talking to families about death and preparing for it, it was actually one of my favourite things to do as a nurse in that setting, because it really allowed them to get all of their wishes across, and for me to try my best in my remit to make that happen. And I found that if their wishes weren't met, or the family didn't understand that they were able to communicate their wishes, that is where complaints and dissatisfaction with the service would come into it.
You did actually touch upon unexpected death. And I just wanted to ask, because from a legal perspective, obviously the times and dates of all records that are made are really important within a clinical negligence claim, because from a legal perspective, if it's not written down, it didn't happen. So in the cases of unexpected death, resuscitation, that sort of thing, how is that actually dealt with? Because I've noticed from records that a lot of the note-taking and record-keeping in those scenarios are written in retrospect.
Yeah, so in a case of acute deterioration, or when deterioration is not expected and it's more in a fast-paced environment and there was no guessing that this patient was going to die or deteriorate so quickly, you are assigned a role in an emergency situation. So you will have different medical professionals that work from A to E. So airway, breathing, circulation, disability and exposure. They will all be in charge of something different, and you will have a dedicated person that is a scribe. So that role will be assigned to a person so that they can record what is happening in real time. Then what often happens is the person that has overlooked the A to E assessment will write in retrospect as to what happened and what was ordered throughout the emergency situation.
So for a solicitor dealing with a scenario like that within their clinical negligence claim, so you're actually looking for who the scribe is, because that record has actually been written contemporaneously. So whilst everything's happening, so that's the actual, in best case scenario then, for want of a better word, that is the one to look at, because they are writing as it's happening rather than everybody else in retrospect.
Yes, so that would be the timed account. It is usually very evident in medical records where that is, because it is all the same writing and it could potentially go on for however long a crash call could be. So it would be from the time that the patient started deteriorating or went into cardiac arrest or deteriorated suddenly, and it would be all the way through, time stamped, everything that was happened, any medication that was given, anything that was done, any decision to stop CPR, they often do that in cases where there is a long period of resuscitation. So they will take a step back, stop CPR, rethink, relook, have a fresh set of eyes, especially considering what time of day it is, if there is a shift change, if somebody needs a break from CPR, if it's those type of scenarios where you will step back and have a fresh look at the patient And even in an emergency situation, it sounds like this is really pre-planned, but it isn't, because it is all done so quickly, because everybody knows their role, that people will step in, step out. But you are looking for that piece of documentation that is written in the same handwriting. It's difficult with computerized records, I can imagine, because that isn't often freehand. So a lot of the entries that you will see in those type of records will be written in retrospect. And the best thing for the scribe is paper and pen, because they are listening to every single thing that is happening in the room, and they are writing it down contemporaneously.
Yes, we have dealt with some circumstances in which I know that a lot of trusts are moving towards having computerized records rather than the handwritten, and there is an element that it can err on the side of not being as detailed as it could be, and that does cause some problems with clarity, especially from my perspective. I'm not a clinician. I rely on those records to be able to determine what I think about the case. And when that is limited, it leaves room for ambiguity, which from a solicitor's perspective, again, as I said earlier, if it's not written down, there's nothing to say that happened. So that does cause a bit of an issue at our end with that. I wanted to ask, obviously you've discussed a scenario of unexpected death. How does that differ in a scenario where it is expected? What differs between the situation you've previously discussed?
So the difference is, obviously emotions are really high, especially if the family are present. If it is a circumstance where the patient is on their own and they have deteriorated, and we don't know any information about that patient, it is so difficult to be able to provide a good death in that circumstance, because you don't know anything about the patient. I'm talking about if a patient is presented in A&E and rapidly deteriorated, you are unlikely to know any of their wishes, anything that they would want to happen, anybody that they would even want there. Sometimes there just isn't time to have that type of preparation when it is unexpected. It is so difficult to deal with death in that point of view, because when you are preparing for an expected death, you do go through a phase of anticipatory grief. So for example, like when my brother, we were told that there was no more treatment, from that point I would probably say me and my family were grieving in a way, because that we knew that it was going to happen. And there is a Kubler-Ross theory on grief and dealing with death, and it is all the different stages of like shock, denial, and all of the in between. And for somebody that has deteriorated unexpectedly in any scenario really, whether that is an accident or within an acute setting, there is no room to prepare. So often when you see a family I have luckily never had those conversations, because I've only worked in those environments as a student nurse and was never expected to have the conversations of, your loved one's passed away, without there actually being some preparation for it. So they haven't had a chance to go through all of those anticipatory measures of anticipatory grief, that that something is happening, that that is to prepare. And what I would say is, when something is expected and you are expecting that person to pass away, there is also a small part of you that when that death actually occurs, there is actually some relief, which can make the grieving process, I don't want to say easier, because grief never is, but it does make it that slight bit more acceptable because you have been waiting for it to happen, whereas for an expected death, I couldn't imagine the feeling of not being able to have that preparation. We hope that you've enjoyed listening to this podcast. It's a difficult topic to cover, but due to my personal experiences, I think it's an important one.